going to take a look at laryngeal cancer. Risk factors: smoking, any form of tobacco use, whether it's a pipe, etc. You know, they really emphasize a pipe and that sort of thing too. A lot of people are like, well, you know, I'm not smoking cigarettes, so I'll just smoke my pipe. Yeah, it's all bad. Also, when you combine the smoking, cigarettes, or what have you with alcohol, that just makes your risk for laryngeal cancer go up, up, up big time. Also, other things like voice abuse, chronic laryngitis, industrial chemicals, like having inhaled chemicals and that sort of thing. Now, on the voice abuse, that is somebody who maybe talks a lot with their job. Now then, signs and symptoms: hoarseness or other voice changes, a lump in the neck, sore throat or feeling that something is stuck in their throat, cough that doesn't go away, problems breathing, an earache. Now that's just the tumor that may be causing pressure on one side, weight loss, and there are no early signs. Now, diagnosis: well, they may do a laryngeal exam or they may do an MRI. They can do a laryngeal exam in the office and look at your vocal cords. Have any of y'all ever had that done? Y'all, that is scary, okay? Because they will grab your tongue with a 4x4 and you'll be surprised just how far out they can pull out your tongue, and then they'll stick a mirror down on there and look at your vocal cords. It's not pleasant, okay? Now, treatment: well, surgery, total laryngectomy. Now, let me emphasize something. In the hospital, there are lots of different types of laryngectomies. You have partial, you have subglottic, and in your med-surg books, they go into great detail about all the different types of laryngectomies. Well, I'm focusing on a total laryngectomy. That is removal of the vocal cords, the epiglottis, and the thyroid cartilage. The whole larynx, not just part of it. Now, I want you to point to your thyroid cartilage. Everybody got it? Look at you. Have no idea where your thyroid cartilage is. Well, it's up here. It's these two flat pieces of cartilage right up here. You don't need them. Let them go. That's part of it. They get rid of the thyroid cartilage too. Now, out of those three things that I have listed there, which one are you most concerned about losing? I heard vocal cords, because I know she's scared that she's not going to be able to talk anymore. Well, you better be most concerned about losing the epiglottis, because that is what covers your airway when you swallow, so you won't aspirate, right? Now, since the whole larynx, remember this includes the epiglottis, is removed, this patient has a permanent tracheostomy or laryngectomy, whatever you want to call it. They will be breathing out of their stoma, not their nose or their mouth, for the rest of their life. Here's a critical thinking exercise. Now, y'all, think about it. If they have removed your epiglottis, that means that you have two tubes going up into your oropharynx, your trachea and your esophagus. So every time the patient swallows, they don't have an epiglottis. So there's two tubes for food and fluid to go down. So they're going to aspirate every time. That is why they cannot lead your trach up into your oropharynx. They have to reroute it out your neck, right? Now, so all of your breathing is done right here. There is not another tube going out into your oropharynx anymore. And we'll talk more about that in just a second. Now, position post-op. What position would you put the patient in post-op? And remember, we just had surgery here. Okay, I heard high Fowlers, I heard mid Fowlers, low Fowlers. Well, which Fowlers is it? That's a lot of Fowlers. Well, I always say this. Pick the one that is sitting up the most, but don't pick high Fowlers. Hey, y'all, you know that you have never seen anyone riding back from surgery, sitting up in their bed straight up like this, riding down the hall, have you? No. Mid Fowlers is fine. Head of bed at 35 to 45 degrees is fine. Do you agree that with any surgery that there's always a little bit of edema? Yeah. But we don't want any edema up here because it is just too close to my airway. NG feedings to protect the suture line, and peristalsis can disrupt the suture line. Some books may say NG feedings because it hurts to swallow. And I'm sure it does hurt to swallow, but what is more important, the pain or protecting the suture line? Protecting the suture line. Monitor the drains if they have any, which would just prevent any fluid from accumulating up in here. Now, also watch for carotid artery rupture, which sounds like a big deal, right? Well, it is. Now, do you agree that because of the proximity of your carotids to the surgical site, that there is a chance that one of them could have become nicked during surgery? Yes. So the patient naturally could hemorrhage. Another thing that we have is called the rupture of the innominate artery. You'll know when this happens because the person begins to bleed massively from the trach. Is it an emergency? Yes. We can't fix it. They need to go to the operating room ASAP. You see, if there is nothing you can do to help the person, that's when you call the doctor. Now, here's another critical thinking exercise. Let me ask you a question. What if it said on the test that you've got a hemorrhaging trach? Which action takes priority? Call the doctor or check the vital signs? What would you pick? You had better call the doctor because you've only got one chance to tell the NCLEX people what the most important thing you would do is. But didn't check the vital signs sound so good? Yeah, because in school what they tell you to do. You better check the vital signs before you call the doctor, or the doctor's going to get mad, isn't he? Well, y'all, the NCLEX people don't care if the doctor gets mad. NCLEX is saying, well, hey, new nurse, if you could do only one thing, what is the one thing you would do here? Well, you better tell them that if you don't do anything else, I promise I'm going to call the doctor, because if you checked vital signs, you're telling the NCLEX people this. Okay, for a pulsating trach, that's the one thing I'm going to do. I'm going to check the vital signs over and over and over again while you die. Now that is not what we're looking for. That's why the answer just doesn't work there. If you use that strategy, that will help you get rid of answers like check the vital signs and that sort of thing. When it says priority, you have got one shot at telling them the most important thing to do. And when you realize that NCLEX is about life and death situations, you'll pick the better of the two that way by thinking the way the NCLEX people think. Frequent mouth care. You decrease the bacterial count in the mouth. NPO people tend to get pneumonia anyway. Well, if they have a lot of bacteria building up in their mouth, that bacteria is going to travel down to their new trach site, or it could go all the way down to their lungs and cause pneumonia. Anytime you've got somebody that is NPO, you better be doing really good mouth care. We're talking about with a toothbrush and with toothpaste, not with a lemon glycerin swab. Y'all, that doesn't help anything. That doesn't decrease the bacteria at all. Now, when the person leaves the hospital, a bib will be used to cover the trach because that acts as a filter, for one thing. Also, there are a lot of body image changes when people have a trach. They feel more comfortable when they have products that they can buy to cover the trach site. Now, when you are selecting something to go over the trach, don't you think it would be important that air would be able to move through it? Why, yes, but sometimes you'll read in textbooks where it will say that plastic can be placed over the trach. Y'all, if you go around selecting plastic on the NCLEX to be placed over the trach, are you going to get a license in the mail? No, because you cannot breathe through plastic. You don't pick things that have a lot of fibers in it either, because that will irritate the trach, like a washcloth and that sort of thing. Also, keep powder and those sorts of things away from the trach too. That's just going to irritate it. Now, a humidified environment helps. You know, when you and I breathe, we breathe in and out through our mouth and nose, so we're warming, filtering, and humidifying the air that we breathe. When you're breathing in through here, you don't have a way to warm, filter, and humidify. So the air is going to be really, really dry. So it irritates the trach, and that's why when you first get a trach, it has a lot of secretions. But as time goes on, the secretions decrease, and a humidified environment will help that. Also, remember with a total laryngectomy, all breathing is done through the stoma. Other treatments for laryngeal cancer are radiation and chemo. Now here's another little critical thinking exercise. Now, let's talk about a trach for a second. Let's pretend that you are working on a night shift, and it's 3 a.m. in the morning, and you decide that you're going to go and do trach care. You go in all confident, and you know that your teacher told you when you are changing the string that you are not supposed to ever move your hand from here, right? You've got to hold it in place, right? But you forgot. And that patient coughs, and the trach just flies out of there and goes right across the room like a missile and lands on the other side of the bed. Tell your friend how you're going to handle this. What are you going to do? Freak out? All right, well, wouldn't it be great if there was a sterile trach sitting there at the bedside waiting for you to reinsert? Wouldn't that be wonderful? But y'all, the answer that you want is never, ever, ever going to be there now, is it? So what else could you do? Sterile Vaseline gauze and tape down 3 sides? What do you think? I don't think we are going to cover the airway. Put your finger in it? No. What are you going to do? So a sterile trach is not there. What else does that leave you to do? So we have got to look for options on this test because the NCLEX already knows the perfect answer that is in your brain. You know that the perfect answer is get a what? A sterile trach. But the perfect answer is never going to be there. So what else can you do if you know it is going to collapse if you wait much longer? Well, you better run over there to the side of the bed and you pick up that trach and you blow it off and you do what? You reinsert. You do whatever you can to reestablish the airway. Now you write that down. Reinsert the dirty trach. And that is going to tear you up because I know what you're thinking. You're thinking, Stuart, it's been on the floor. That thing is dirty. It's gross. They'll kick me out of nursing school if I do that, right? And let me tell you something. Would you rather be alive with an infection or dead without one? Now you tell me. Look at her. She's dead, completely dead. But she's infection-free. Now that is just not nice. You keep them alive and you reestablish the airway. And as soon as you can get a sterile trach, you get it in there. Now when you have situations where you need an emergency tracheotomy, like with the burn people we were talking about, that is when you use a trach tube versus a laryngectomy tube. It has a slightly different shape than the laryngectomy tube. People go home with a trach, but they are called the laryngectomy tubes then. A laryngectomy tube is smaller around. It is the same thing as a trach, but it has a different name. It's a longer term thing, okay? You use it forever. It's a smaller around and it's not as long either. Now before we leave the laryngectomy client, let's talk about speech rehabilitation. If you can't talk in a way that people understand you, then that is going to impact many of the activities of your life. Do you agree? What about your job? What about social relationships? How about love relationships? A lot of different things. Now you say, well, I can text and email, and yes, you're right, but sometimes you just have to let it all out and talk, right? Well, we all agree if we could never talk again, then that would be a pretty big deal, wouldn't it? Okay, so this is going to be a priority from the patient's perspective. Do you think the inability to communicate can cause fear, maybe some anxiety, depression, self-esteem, altered body image? Yes. So let's be a good nurse and help them out. When do you think that this client teaching should begin? I heard you say it. On admission, yes, preoperatively. Y'all, in the NCLEX, they want to be sure that you are going to see that your clients get referrals to support groups that are designed to promote the highest quality of life that the client can achieve after this radical surgery. They want to be sure that you are a good patient advocate. Now, what I'm trying to say here is that anytime you have a client who is going through a life change or a crisis, use community support groups. Whether it's a mastectomy, a new baby, an amputation, neurological injury, think rehab and community support. You will make the client happy and the NCLEX lady. So refer them to the International Association of Laryngectomies or the American Society. See if there are any local groups like the Lost Chord group. Any of these groups will usually have a pre-op visitation program to assist the client. You also need to set up some form of communication to use post-op, and be sure to test it out pre-op. Make a communication board with pictures of common activities like food, bathroom, pain, hairbrush, etc. Be sure you have a writing board for hard to identify problems. Hey, be a good nurse and find out what hand they write with and put the IV in the other extremity. Now, what about speech rehabilitation? You have all seen the handheld device that they hold up to their cheek or neck and it vibrates while they form words. It's called an electrolarynx. And well, the voice quality sounds like a robot, so it's not usually the best choice. Some clients are taught to swallow air and then belch it back up and try to form words with their lips. This technique is very difficult and most just give up. The most common device is called a Blomsinger device. Either at the time of surgery or after, a connection is made between the trachea and the esophagus. Once the fistula heals, the client can insert this soft plastic device and move air from the lungs to the trachea and then over to the esophagus and out the mouth. In the mouth, the tongue and lips can form words with the rush of air. Now, I know that the first thing you thought was aspiration. You are worried about food going down the passageway and into the lungs. Well, it can't happen because it is just a one-way valve and nothing can be pulled from the esophagus into the lungs. The client just keeps it clean and mucus-free. Now, just a few more things about total laryngectomies. Now, when I said total, what did I say that meant? That there's no trachea going up here. Everything's coming out. It's coming out here. Okay, so can the client with a total laryngectomy whistle? What do you have to be able to do to whistle? Pull air in. Well, you can't do that. Can you drink through a straw with a total laryngectomy? If you don't have a trach going up into here, your oropharynx, can you drink through a straw? No, because you have to be able to form a suction, right? So it would just be mean for you to go up to your little patient and say, okay, now drink your apple juice, Paw. Now suck on the straw. No, that would be mean. They can't. Now, could I smoke? If I'm breathing in and out through my neck, can I smoke? Not recommended, is it? Now, don't get me wrong. You'll see people in those casinos or in those dive bars smoking through their trach right here. But y'all, that is not recommended. But I can still smoke through there if I want to. What if I have a total laryngectomy and I have been a world champion swimmer forever, and now I've got a trach? Can I go swim? Well, let's say I've had a trach for 4 to 5 years. I'm really, really used to it. Can I go swimming? Not recommended, right? No. Now think about it. Y'all, I'm breathing in and out through my neck. So when I go over here and dive off the deep end, what's going to happen? Drown, right? Now let me make you feel a little bit better. I've had people that came up to pass boards, that went on to pass boards that said, now Stuart, yes, they can go swimming if they plug up their trach. Now y'all, are you going to get a license in the mail if you go around plugging up people's trachs? No. Let's not do that. Let's move on to something easy. Suctioning. Do we use sterile or non-sterile technique? Sterile. Hyperoxygenate when? Before and after. Now, when do you stop advancing the catheter? When they cough or meet resistance. Either one. Now, put a star by meet resistance. Now, don't get me wrong. They're going to cough too, and that is a sign that you need to stop. But some people, you tell them that they're about to get suctioned, and they just start coughing anyway, right? The catheter hasn't even gone in yet, and they start coughing. Now, apply suction when? On the way out. And do we use intermittent or continuous suction? Intermittent. Y'all, you are a mean nurse if you do it continuously, right? Don't be mean. And suction no longer than 10 seconds. Watch for arrhythmias because which nerve can be stimulated? The vagus nerve. And when the vagus nerve is stimulated, the heart rate drops. Okay, so you're suctioning somebody and the heart rate drops. That is not hypoxia. Because when you are hypoxic, what does your heart rate do initially? It goes up. So I know I stimulated the vagus nerve if they have become bradycardic. So what do? Well, stop suctioning and do what? Hyperoxygenate. That's right. Stop suctioning and hyperoxygenate. Now let's look at colorectal cancer. Look at the risk factors. It may start as a polyp. 2 out of 3 of colorectal cancers begin in the rectosigmoidal region. And the most frequent site of metastasis is the liver. Now, when you get into liver metastasis, that's when the patient is going to have a lot of bleeding problems, right? Yes, lots of bleeding problems. They're going to become jaundice, and they're going to start retaining toxins, and they can't break down drugs either. And we're going to take bleeding precautions with this person, which we're going to talk about more a little bit later. Other problems to watch for: bowel obstruction. They can perforate. They can develop a fistula, which goes into their bladder and into their vagina. In other words, that cancer is eating away into other internal organs. And risk factors. 95% of those who get colorectal cancer are greater than 15 years of age. Inflammatory bowel disease. Y'all remember on the first page on the oncology section, we said chronic irritation brings about cancer? Well, inflammatory bowel disease is chronic irritation and inflammation. Genetic predisposition, like a family history. Dietary factors for colorectal cancer, like refined carbs, low-fiber diet, high-fat diet, and red meat. Fried and broiled foods. Now, some people look at the broiled foods and they say, well, what's the deal with that? I thought broiled foods were really healthy. Well, it is healthy, but you don't want to overcook. The burned and charred part is what is considered to be unhealthy. That's the part that has most carcinogens. Grilling on the grill is a good thing, but you don't want to do anything too much because that charred part is what has the carcinogens in it. Now, if you have a first-degree relative with colorectal cancer, your risk just increased 3 times the norm. So family history is extremely important here. And just because you've got somebody with a history of cancer in your family doesn't mean you're going to get cancer. It means that if you do get cancer, you will get the same kind of cancer. That's which way you have to think of that. Now, 95% of those who get colorectal cancer are greater than 50 years of age. Diagnosis. Screening. Fecal occult blood testing should begin at 50. Flexible sigmoidoscopy should be performed every 5 years, or a colonoscopy every 10 years after the age of 50. The definitive test for colorectal cancer is a colonoscopy. Now, signs and symptoms. Well, change in the bowel habits, like constipation or diarrhea or narrowing of the stool. You'll hear about people that have diarrhea and then are constipated, then diarrhea, then constipation. A change in the bowel habits is what they say. Now, blood in the stool, cramping or abdominal pain, feeling like you need to have a bowel movement that is just not relieved by doing so. Weakness and fatigue. They may be anemic from occult blood loss, abdominal fullness, and weight loss. Anytime someone has cancer and they start dropping pounds rapidly, unexplained weight loss, then that cancer is on its way. Because when cancer is inside the body, you're in a hypermetabolic state, right? So you're burning more calories. All right. They may become obstructed. Now, with an obstruction, you may see visible peristaltic waves. And that just means when the patient is lying flat, you can see their abdomen rolling. It's just trying to push through the obstructed area. Now, also with high-pitched tingling bowel sounds, and pain will occur. Now, treatment. Surgery, radiation, and chemo. They may do all 3. And the drug of choice is 5-FU. They may have a colonoscopy post-op and a colectomy. Well, part of the colon is removed, and with that, they may need a colostomy. It just depends on how much got removed. And they may have a very radical surgery known as an abdominoperineal resection. That is removal of the colon, the anal area, and the rectum. So it is very radical surgery. Now, can you take a rectal temp on this patient? Well, there's no rectum, so you can't take a rectal temp, right? No. Don't take rectal temps on anybody if they are thrombocytopenic, have had an abdominoperineal resection, or any form of immunosuppression. That is a rule. That is just a nursing rule. Now, bladder cancer. Well, risk factors. The greatest risk factor is smoking. The nicotine from the smoking irritates the lining of the bladder, okay? And exposure to other chemical toxins can cause it too. Now, major symptoms: painless, intermittent, gross, or microscopic hematuria. Now, since it is painless, that is one of the major reasons why people do not seek health care. Because if they're not hurting, they think, well, they'll just get over it. A lot of people think, well, I must have hurt myself some way, and they will just go on bleeding. Now, diagnosis. They are going to do a cysto, and treatment. Well, surgery, where they may remove all or part of the bladder. Now, y'all, sometimes they can just instill chemo directly into the bladder and kill the cancer, or they can go in there and just remove the tumors. It just depends on how advanced the cancer is. If they remove all or part of your bladder, you may have what is called a urinary diversion or urostomy, and a common urostomy is called an ileal conduit. Now, what they do there is they take out a piece of your ileus and turn it into a bladder. You see, they took out your bladder because it had cancer. It's gone. They have removed a section of your intestines and made it into a bladder. Remember that your intestine is shaped like a straw, so they plug into one end of the straw your ureters. Then the other end is brought to the abdominal surface as a stoma, and that is what they wear the bag over. It drains urine continuously, and they don't have any control over this. Okay, now post-procedure. The patient may be impotent. Now here's the deal. With any surgery of the reproductive or urinary tract in a male, there is always a chance of impotency because do they cut nerves? Yes, which we're going to talk more about those nerves later. There's always a chance, and that is why it says maybe. Not everybody is. Now, hourly outputs. Y'all, it is a rule that anytime you've got somebody that has urinary tract surgery, you better make sure their urinary output never drops. After a urinary tract surgery, you never want a decrease in the urinary output. That is always a bad sign. We have got to increase fluids. They need to drink 2,000 to 3,000 milliliters a day to flush out the conduit. Now, is mucus going to be normal in this urine now? Yes, because what is the bladder made of? Intestine, and intestine always makes mucus. Now, change the appliance in the morning time because this is when urine output will be at its lowest. Now, a lot of people think, well, the first thing that I do when I get up in the morning is go to the bathroom. So what's the deal with this sentence? Well, here's the deal. All during the day with this person, we've got them drinking a lot of fluid, right? To keep the conduit flushed out. So naturally, they are draining urine all the time in the bag, and they can empty the bag throughout the day. But when you have slept all night, they have gone all night without drinking fluids. So that's why their output is lowest in the morning. That is why, when you want to change the appliance and do their skin care around their stoma, because do you want urine draining everywhere? No, that's just going to irritate the tissue. And it says on your handout that it is okay to place a little piece of 4x4 inside the stoma during the skin care to absorb any urine. Just don't forget to remove it. You never want to put anything inside the urinary tract to clog it up. Because if urine can't come out, that could cause renal failure. That's why earlier when we were talking in the burn section, those cells breaking down, clogging up the kidneys, the urine can't get out freely. Now on the next page, prostate cancer. Signs and symptoms. Well, this patient comes to the doctor with signs and symptoms of benign prostatic hyperplasia, BPH. Signs and symptoms like hesitancy, frequency, frequent infections. You see, people with prostate trouble and an enlarged prostate, they have frequent infections because are they able to empty out the bladder completely? No. So they have stagnant urine in the bladder. Now they may have nocturia, and that's one that really irritates them the most. Waking up every 10 minutes, feeling like they have got to go to the bathroom. Their wife is saying, well, you just went to the bathroom. But they have an urgent need to go to the bathroom because they are never able to empty their bladder. Urgency and dribbling. Now the most common sign is painless hematuria. Well, see, the patient is having all these symptoms. They may or may not have the painless hematuria, but even if they have the urgency, the nocturia, and all that, they are going to go to the doctor. The doctor is going to do a digital rectal exam, and that's the first thing they're going to do. And the prostate may feel hard or nodular, or the doctor doing the prostate exam may feel one little nodule. That's still not normal. If you feel anything hard or nodular in the prostate area, that usually means cancer. So they'll do more investigation. Now, diagnosis. Well, lab work. Your prostate-specific antigen, your PSA. PSA, y'all, that is a protein that is only produced by the prostate. Normal is less than 4, and the digital rectal exam. Now, on the rectal exam, the prostate will be hard and enlarged. These two checks are done together and are our most important screening checks. And if you have 2 or more first-degree relatives with prostate cancer, you need to start PSAs by at least age 45. All males with their routine yearly or physical exam might as well go ahead and get their PSAs drawn. It's a blood test, and keep up with it. Now the thing is, you are looking for changes in the PSA. You can have a PSA that is still within normal limits, but it's elevated from the last time, and that could mean problems. It doesn't have to be way out of whack to be abnormal. That's why it's important that everybody keep up with their PSA. Also, alkaline phosphatase. If this increased, that means bone metastasis, and that is with any kind of cancer. They will check the alkaline phosphatase, and if the alkaline phos is up, that means bone troubles. Now, prostate cancer in particular likes to go to the spine, sacral area, and pelvis. Normally, when you have someone presenting with prostate trouble and they're having bone pain, that is a late sign. And bone pain, like bone cancer, is one of the most painful types of cancer in the whole wide world. Another test that they will look at with prostate trouble is an increased acid phosphatase. They may also do bone scans, liver scans, and chest x-rays looking for metastasis. Now, a biopsy. When prostate cancer is suspected, a biopsy must be done for confirmation prior to surgery. And treatment. Well, there are different ways to treat it, and one way is called watchful waiting. You know, if you are already 82 years old and they tell you that you've got prostate cancer, a lot of patients just choose to do nothing because it's such a slow-going cancer and the treatment can cause a lot of troubles too. So that's why they just say in some people, watchful waiting in early stages. In asymptomatic older adults with other illnesses, so the treatment could make their quality of life even worse. They may choose not to do anything. Surgery. In other people, they may do surgery like a radical prostatectomy. That is done when the cancer is localized to the prostate. That means they can go in there and take out your prostate and then you're cancer free. All right, now they may have erectile dysfunction due to pudendal nerve damage. They can also be incontinent, and that's why we have to teach them to do the Kegel exercises. And some people, after they have that radical prostatectomy, have to wear a urine bag from now on. They can get into other surgeries where they can go in and do different things to control the urine flow, but that's getting into really detailed types of surgeries. The patient is sterile, okay, because the semen is not going to be coming out like it used to. This is when your teacher taught you about retrograde ejaculation and that sort of thing. Now, if there is no lymph node involvement, no increase in acid phosphatase, and no metastasis, the surgeon will try to preserve the pudendal nerve. Now, you may be thinking, well, why wouldn't they try to preserve it anyway? Well, because if they're not feeling comfortable, they don't want to take a chance of leaving any cancer in there is what I'm saying. And that might be the payoff for being cancer-free, is having damage to that nerve. All right, let's look at the next thing we have, prostatectomy. Another type of prostatectomy is called a TURP. Now, why am I going to talk about that here? Because a TURP is the most popular prostatic surgery in the country. This is the main type of prostate surgery we see, and that's why we have to talk about it. Now, it's transurethral resection of the prostate. It is usually reserved for BPH to help urine flow. Your prostate is shaped like a donut, okay? And the urethra goes through the center. So if your prostate swells, it clamps off the urethra. So the urine can't get out, and that's why the patient becomes so symptomatic. Now, the reason it's so popular is that there is no incision. They go in through the urethra. And the most common complication? Bleeding. Don't get me wrong. They're going to bleed. Bleeding is normal, but I'm talking about excessive bleeding here. Now, with other procedures, you have to explain the risk of impotency and infertility, because with other procedures, they do have an incision which could damage the nerves. Is it normal to see bleeding after this surgery? Yes, but I'm still worried about it because can bleeding clog up my kidneys? Yes, that's why we have the continuous bladder irrigation to maintain patency and flush out clots. If you get clots in the urinary tract, you may be about to have renal failure too. You've got to have a special catheter, a three-way catheter, and you never want kinks in the tubing. If that drainage tubing gets kinked up, then the urine can't drain out. And would that cause pressure on the suture line? Yes, that can mess up the entire surgery. Now, you've got to subtract the irrigant from the output. So you've got urinary tract surgery here. You have got to keep up with the output, don't you? Because we are so worried about kidney damage. But you're putting a lot of irrigant in with this urine to keep the clots flushed out, so you've got to keep up with how much irrigant you're putting in so you can subtract it to know what the exact output is, right? Now, how are you going to know how the kidneys are working if you don't know the exact output? Rule: never hand or manually irrigate the catheter with fresh surgeries without a doctor's order. Y'all, do you agree with any surgery, with any fresh surgery, that you shouldn't be messing with tubes like NG tubes, catheters, and irrigating things? Yes, the surgery is in too fragile of a state for a brand new nurse to be fooling with it. All right, now what drug do we give for bladder spasms? Well, one is a BNO suppository, and another is ditropam. Now let's pretend that you've got a patient who has just had this surgery, and they're on the call light hollering for you to get out there because they're having bladder spasm, bladder spasm, bladder spasm. They're hurting so bad, you hurry up with that suppository. So you go in the room. Now, would you assess first? Which one would you assess first? The tubing for kinks or the bladder for distension? Ask your friend. Now, I know what you're thinking. You're thinking you're going to check them both, right? Well, yeah, we hate to pick between answers like that, but the NCLEX loves to put you in a bind. That's what the NCLEX is all about, putting you in a bind, making you pick between two answers that you don't want to pick between, because you know you're going to do both of them, right? Well, So here's my strategy. You always assess prior to selecting an implementation answer, and always assess the patient first. So bladder distension would be your answer. That's the patient, isn't it? Yeah, the bladder distension. Y'all, if you're not getting all of our critical thinking exercises right, don't worry about it. That's why you're taking the class. Believe me, we've got a lot more of the exercises to go through. And if we gave you scenarios all week long that everybody got right all the time, what would you leave here thinking? Oh, I'm good, girl. Yeah, I didn't need that. Well, we need to be challenged while you're in here. It's better to be challenged now than when you're sitting at the computer in the testing center. Okay, now back on your notes on TURP treatment. Now, when the catheter is removed, what do you need to watch for? Retention, urine retention. Because you know, when you have a catheter in for a while, things don't just kick in and work like they're supposed to, right? So watch for urine retention. Temporary incontinence is expected. That's why we encourage the perineal or Kegel exercises. The patient needs to avoid sitting, driving, or continuous exercise, and don't lift too much. Any of that can make you bleed, right? Now, what's Colace? It's a stool softener. They don't need to be straining. Straining will make you bleed. They need to increase fluids to flush blood out, because could that blood make a little clot and clog up your kidneys? Absolutely. Now, before we move on, let me clarify something. I talked about the TURP in the middle of all this, okay? Now, you do not have to have had prostate cancer to have a TURP. There are people in the world that just had prostate hyperplasia, and they will need a TURP to relieve the symptoms. But sometimes, say you've got prostate cancer that's already metastasized out into different places, they may do this as a comfort measure where your urine can come out more easily. Does that make sense? Okay. A TURP is not going to cure prostate cancer, it's just symptomatic relief. Other treatments for prostate cancer, well, we have radiation, chemo, and they can do hormone therapy. And one thing they can do is bilateral orchiectomy to decrease testosterone. They can also give estrogen to fight testosterone. And they can give Lupron. Lupron in the male will decrease testosterone. And last but not least, stomach cancer. All right, risk factors. Well, H. pylori has been associated with it. They won't say that it causes it, but they do say it has been associated with stomach cancer. Also, there is a higher incidence of stomach cancer with people who have pernicious anemia and achlorhydria. That's when you don't have enough acid in your stomach, no acid in your stomach. It is also related to eating pickled foods, salted meats, fish, nitrates, and increased salt. Or the surgery of Billroth II, which is a partial gastrectomy. Like if you had a bad peptic ulcer and they removed part of your stomach, that can cause atrophic gastritis. Also, other risk factors, well, there's that tobacco and alcohol again, especially in the presence of each other. Remember I said they act synergistically. They are co-carcinogenic. Now, signs and symptoms. The most common are heartburn and abdominal discomfort. Now, other signs, like loss of appetite, you have weight loss, bloody stools, coffee ground vomitus. Jaundice tells us who's gotten involved now. The liver's in it now. We've already got some metastasis when the liver's involved. Epigastric pain, back pain, and a feeling of fullness. You will see people that will present saying, I'm just hurting a little bit right here. And, I can eat 3 bites and just be full. Well, that's because the tumor is taking up part of their stomach, right? Yeah. All right, also anemia. Stool may be positive for occult blood. Achlorhydria, that's no acid in the stomach. And they also will do an upper GI, a CT, or they may do an esophagogastroduodenoscopy. In other words, they're going to scope you to see what's going on in there. Now, the most common signs for a GI obstruction are abdominal distension, nausea and vomiting, pain, and normally what they do there is they make you NPO and put an NG tube to suction for decompression. Now treatment. The preferred treatment is going to be surgery. So gastrectomy. Now y'all, that might be a curative surgery. If they can go there and take out part of your stomach and you're cancer free, well that's great. But more likely what they're going to do here is a debulking of the tumor. Now when I say debulk, I just mean they're going to go in there and take out all they can, right? Because normally with gastric carcinoma is what they call an adenocarcinoma. And when you have adenocarcinoma in one part, you've probably got it in other places already, and it just hasn't presented itself yet. So what they will do is debulk the tumor, but try to leave you just a little bit of stomach, like a 30 milliliter pouch, so you can still eat and drink with some degree of normalcy. Now post-op, Fowler's position. In other words, you're sitting them up a little bit to decrease stress on the suture line, right? They will have an NG tube for decompression, and is it okay to reposition that tube? What if it stops working in the first 24 hours post-op? What would you say? I just told you a minute ago, with fresh surgeries, leave it alone and call the doctor. You don't want to mess with fresh surgery tubes. They're afraid we'll disrupt the suture line, and that's what they're scared of. They're afraid we'll disrupt the suture line. Now, don't get me wrong. When somebody comes back from a gastrectomy, we're going to have the NG tube down and hooked to suction. But remember, I just said we have a small 30 milliliter pouch. It's going to bleed in there some. It's a fresh surgery. So do you want a lot of blood accumulating in my little pouch? No. It's going to rupture my stomach, see? That's why you watch the blood, but don't you mess with the tube. It's too fresh. All right, now, 2 complications of a gastrectomy. Well, one complication is dumping syndrome, which we're going to talk more about that in the GI system. And then another complication is B12 deficient anemia, also known as pernicious anemia. So at the top of the page, I said that pernicious anemia can be a risk factor for getting cancer, but another way to look at it is if they take out your stomach, now you're going to get pernicious anemia. Now, one way they diagnose this is with what they call the Schilling's test. This measures the urinary excretion of vitamin B12 for a diagnosis of pernicious anemia. The Schilling's test will only tell you about pernicious anemia. It will not tell you about any other type of anemia, like iron deficient anemia. If they put that Schilling's test on an iron deficient question, you would not pick it. It only tells us about pernicious anemia. Now, here's how pernicious anemia works. Well, they took out your stomach, didn't they? Yes. No stomach, no intrinsic factor. If we don't have intrinsic factor, you can't absorb oral B12. Now, I said oral B12. If you can't absorb oral B12, well, you cannot make good red blood cells, so you are going to become anemic. Now, how do you feel when you're anemic? Yeah, just tired, your heart beats real fast, pale conjunctiva. You know the signs and symptoms of anemia. Now, what will they do here, or what they will do here is this. I said the patient cannot absorb oral B12. So what am I going to have to take? B12 shots. I can absorb IM B12. So they are going to give me the B12 shot every week for a month, and then like monthly after that. They will give you the B12 shot every week for a month, and then monthly after that. All right. Now, other treatments for stomach cancer are chemo, and I've listed for you some common drugs there. And then they can also do radiation. It just depends on the type of cancer that you have. All right. That concludes oncology.